Welcome back, everyone, to the Deep Dive. This is Deep Dive number 8 for your Abnormal Psychology course at LACC, Los Angeles City College.
That's right, Module 8 already.
We're officially on Module 8, and look, we're tackling a subject today that it's incredibly difficult. It can be painful for people to confront, but it's absolutely essential for anyone studying human behavior. Substance-related and addictive disorders.
It really is a critical module, and it's dense. For you, especially, living and studying here in Los Angeles with all the intensity, the pressures around careers, ambition, just the financial stress, plus complex family stuff, relationships, understanding addiction issues isn't just like academic theory.
No, not at all.
This knowledge, honestly, is going to profoundly inform your future career path, whatever that might be, plus your own decisions, and really how you interact with people every day.
Yeah, our mission today really is to try and move past the easy stereotypes, the judgment you often hear, and get to a place of, well, clinical clarity, but also deep empathy.
Exactly. It's critical knowledge for being, well-informed, but also compassionate.
So let's try and unpack this module. Maybe we can start by defining the core concept. What exactly is a substance use disorder according to the clinical criteria?
Okay. So the DSM-5, that's the manual we use, defines substance use disorders, or SUDs, by this compulsive pattern of using a substance that ultimately leads to a significant impairment or distress in someone's life.
Okay, significant impairment or distress.
Right. And we're looking for a specific set of 11 symptoms. These cover everything from, impaired control over use to social problems, risky use, a whole range.
That distinction seems really important, the difference between just using a substance sometimes and having a disorder. When you say impairment, what does that actually look like in real life?
Well, it means real consequences.
Yeah.
So the person might be spending a huge amount of time just trying to get the substance, use it, or, recover from its effects. Or they might start dropping the ball on major life roles, school, maybe work, family responsibilities. Things start to slide because the substance use takes priority.
Got it. And the module mentions 2 specific physiological changes as major indicators.
Yes, exactly. Tolerance and physical dependence. These really point towards the severity of a disorder.
Okay, so tolerance is when your body adapts, right? You need more and more of the drug to get the same effect you used to.
Precisely. The body gets used to it, and physical dependence is what causes withdrawal symptoms.
Right. That's when stopping the substance makes you feel physically sick or mentally distressed.
Yeah. And withdrawal can range dramatically from, say, mild anxiety or irritability to really dangerous, even life-threatening symptoms like seizures, depending on the specific drug.
Wow.
So when you see both tolerance and withdrawal happening, that usually signals a severe disorder, and that definitely needs specialized care.
Which brings us to treatment, I guess.
Right. And that's why the module emphasizes this. Effective treatment isn't just one thing. It's usually a combination tailored to the person.
Like what kind of combination?
Typically psychological therapy, behavioral interventions, and sometimes medication, pharmacological approaches. The goal isn't just stopping the use, but managing that underlying dependence and really supporting long-term recovery.
Okay, that makes sense. It's complex. Maybe we should shift gears a bit and look at how these substances actually work in the brain, because you mentioned the treatment depends on that.
Absolutely. The mechanism is key. All these substances are psychoactive, meaning they alter brain function. They affect consciousness, mood, thoughts.
How do they do that?
Basically, they hijack our brain's natural chemical messaging systems. They act either as agonists, meaning they mimic or boost the activity of our natural neurotransmitters, or as antagonists, where they block that activity.
Okay, agonists in hand, antagonists block. So the module breaks them down into 4 main categories.
Yes, and the first one is the substances that generally slow the system down, the depressants.
Right, slowing down the central nervous system.
Exactly. They mainly do this by enhancing the GABA neurotransmitter system. You can think of GABA as like the brain's primary inhibitory signal, or its main brake.
So boosting GABA makes things calmer, sedated.
Yep. It induces calming, sedation, sometimes intoxication. The big examples here are alcohol, barbiturates, and benzodiazepines like Xanax or Valium.
Okay. And their effects can range quite a bit, right? From just feeling relaxed initially to slower thinking, slower reaction.
Definitely. And within depressants, alcohol use disorder, or AUD, is obviously a huge focus. The module points out this absolutely staggering lifetime prevalence, 29.1% in the U.S.
Wait, nearly 1 in 3 people in the U.S. will meet the criteria for AUD at some point?
That's what the data suggests. It's huge. It affects physical health, mental health, across all demographics. It's massive.
Wow, that statistic is
That's all, yeah.
humbling. Given how common it is, how does the DSM-5 categorize it? Is it all or nothing?
No, it uses those 11 symptoms we mentioned earlier. Based on how many symptoms are present, it's classified as mild, moderate, or severe.
And severity links back to things like cravings, not being able to cut down.
And definitely tolerance and withdrawal. Those usually point towards a severe classification.
That prevalence figure really makes you think about the social context, doesn't it? How integrated alcohol is in, well, everything from socializing to stress relief.
It certainly does. It highlights those factors. Okay, so if depressants slow us down, what about the ones that speed things up?
Right, then we move to the stimulants. These increase the overall level of activity in the brain. And you mentioned the addiction mechanism is different here.
Very different, and often more immediately risky in terms of addiction potential.
Yeah.
Stimulants mainly work as agonists, boosters of the dopamine system.
Dopamine, that's the reward chemical, right? Pleasure, motivation.
Exactly. It's tightly linked to the brain's core reward pathways. By flooding those pathways, stimulants create intense feelings of pleasure and reinforcement, which makes the risk of compulsive use very high.
And we're talking about things like
Cocaine, amphetamines like Adderall, when misused MDMA, which you might know as Molly or ecstasy, nicotine, and even caffeine, though obviously on a different scale.
that link to reward seems crucial, especially thinking about, our listeners navigating the competitive LA environment, that
Yeah.
drive for ambition.
Absolutely. Stimulants give that immediate jolt, more alertness, more energy, faster heart rate, higher blood pressure. People feel like they can do more.
But the downsides are serious.
Oh, definitely. Paranoia, aggression, anxiety, plus major risks for cardiovascular problems, heart attacks, strokes. It's a dangerous trade-off.
This connects back to something you mentioned earlier, cognitive approaches, like
Yeah.
expectancy theory.
Precisely. This is a perfect example. In a high-pressure environment, like college finals or starting a demanding career, someone might use a stimulant not just for the euphoric feeling, but because they expect it to boost their performance.
Like, this will help me focus, or this will let me pull an all-nighter.
Exactly. They expect a functional benefit. And that expectation, based on maybe one positive experience or just hearing about it, can strongly motivate and reinforce the use even before physical dependence really sets in. It becomes a tool, or what feels like one.
Kind of like the self-medication idea, but applied to performance or ambition instead of just anxiety.
That's a great way to put it. You're trying to perform better under pressure, using the substance as a perceived shortcut or enhancer.
So treatment then has to address those thoughts, those expectations.
Absolutely. Behavioral therapies like CBT, cognitive behavioral therapy, are key, and motivational interviewing, helping the person challenge those beliefs and find healthier coping strategies. Sometimes medication can help manage withdrawal too.
Okay, moving on. The next category is known for pain relief and euphoria, right? The opioids.
Yes. This includes natural opiates derived from the poppy plant, like morphine and codeine, but also semi-synthetic and synthetic versions like heroin, oxycodone, hydrocodone, fentanyl.
And how do they work?
They essentially hijack the body's own pain relief system. We have natural endorphins that bind to opioid receptors to reduce pain and create feelings of well-being. Opioids bind to those same receptors, but much more powerfully.
Leading to strong pain relief, but also that intense euphoria.
Exactly. And that powerful euphoria is a major driver of their high potential for abuse and dependence.
The opioid crisis is just devastating. The module mentions how often it starts, maybe innocently, with prescription painkillers.
That's a tragic reality. Someone gets prescribed an opioid for legitimate pain after surgery or an injury, but the body develops tolerance and dependence incredibly quickly. Soon, the person finds they can't control their use, and they continue using despite really serious negative consequences. Those are the hallmarks of opioid use disorder, or OUD.
And treating OUD sounds particularly challenging.
It requires very specialized, often long-term support. A cornerstone of treatment now is medication-assisted therapy, or MAT.
What does that involve?
It uses medications like methadone or buprenorphine. These are also opioids, but they act differently. They reduce cravings and prevent withdrawal without producing the same intense high. They stabilize the person.
So it's not just a quick detox.
Often not. For many people, MAT is a long-term maintenance strategy used alongside counseling and psychotherapy. It helps manage the physical dependency, which is incredibly strong with opioids, and reduces the risk of relapse and overdose, which is tragically high.
Okay, that's really important context. And the final category, hallucinogens.
Right. These are substances like LSD, psilocybin from mushrooms PCP, also known as angel dust, and ketamine.
Hmm.
These work differently again. They profoundly alter perception, mood, and how you sense the world around you.
Inducing hallucinations, obviously, but also feelings of detachment.
Yes, altered states of consciousness are the main effect. Now, it's important to note, as Amada points out, while they are definitely psychoactive and can cause bad reactions like temporary psychosis or intense anxiety, their primary mechanism doesn't usually target that core dopamine reward pathway in the same powerful reinforcing way that stimulants or opioids do. So, generally speaking, their potential for creating compulsive addictive use patterns is lower compared to the other categories.
But they still carry risks, right? The module mentions something called HPPD.
Yes, hallucinogen persisting perception disorder. This is a rare but documented condition where someone experiences chronic, kind of like visual static or trails or brief flashbacks of the perceptual distortions long after the drug is out of their system. It's not psychosis, but it's distressing.
So even without strong addictive potential, there are unique dangers.
Absolutely. It underscores that risk isn't only about addiction or dependency. Altering the brain's fundamental processing systems can have lasting consequences. Treatment here is mostly supportive therapy to cope with perceptual issues, maybe medication for anxiety.
Okay, so we've covered the four main types, how they work, the specific disorders. Let's zoom out again. What does the module say about the causes? Why do some people develop these disorders and others don't? It's clearly not just about the drug itself.
Not at all. The module is very clear. Addiction isn't a moral failing. It's understood now as a complex brain disorder driven by this intricate interplay of factors: genetic, biological, psychological, environmental, social. It's multifactorial.
Let's break that down. Genetics plays a big role.
Huge. The module cites heritability estimates for alcoholism, for example, somewhere between 40 and 60%.
Wow, 40 to 60%. So a significant chunk of the vulnerability can be inherited.
Yes, it doesn't mean you're destined to develop it,
Yeah.
but your genetic makeup can significantly predispose you, especially when interacting with environmental factors. It's genes plus environment.
That's humbling, realizing how much might be sort of set up biologically or by early experiences.
Yeah.
What about the psychological side? You mentioned cognitive approaches earlier.
Right. Research shows that people struggling with SUDs often have measurable differences or maybe impairments in cognitive control and executive functions.
What are executive functions?
Things like inhibitory control the ability to resist impulses, to say no to that immediate urge. Or attentional control, being able to stay focused on longer-term goals instead of just seeking immediate gratification, decision-making, planning, those higher-level brain functions.
Okay, and how does that link back to expectancy theory?
It links directly. If your inhibitory control is maybe weaker and you're under stress, maybe exams at LACC or a tough situation at home, and you hold a strong positive expectancy about what a substance will do for you.
Like this drink will make me relax,
Yeah.
or this pill will help me steady.
Exactly. If you strongly expect that positive outcome and your ability to inhibit the impulse to seek that outcome is compromised, it becomes incredibly difficult to resist, even when you start seeing negative consequences pile up. The expected benefit outweighs the perceived future cost.
That really makes you think, doesn't it? Especially here in LA, with all the pressures. Are people using to genuinely self-medicate an underlying issue, or just more about chasing an expected feeling relief, focus, confidence that the environment reinforces?
That's a fantastic question for self-reflection, isn't it? And it's often a mix of both, probably. But understanding that expectancy piece is crucial.
And the environment itself plays a huge role too, obviously.
Definitely. Behavioral explanations look at learned associations. Positive reinforcement is the high, the pleasure. Negative reinforcement is the relief from withdrawal or stress or anxiety. And environmental factors like, how available drugs are, peer pressure, lack of parental supervision, all significant contributors.
The module also highlights adverse childhood experiences, ACEs.
Yes, and this is critical. There's strong evidence that early life trauma, neglect, instability, those ACEs, can significantly increase a person's vulnerability to developing SUDs later in life. It can impact brain development, coping mechanisms, attachment. It really sets the stage.
So putting it all together, the genes, the brain function, the beliefs and expectations, the childhood experiences, the current environment, wow. It's incredibly complex.
It really is, which is why treatment can't be one size fits all. It absolutely has to be comprehensive and tailored to that individual's specific mix of factors.
What does that look like in practice?
Well, it often starts with detoxification, if needed, to manage withdrawal safely. But that's just the first step. Then comes robust behavioral counseling, maybe medication like we discussed for opioids or alcohol, and crucially, screening for and treating any co-occurring mental health issues like depression or anxiety. Addiction rarely travels alone.
And for preventing relapse long term, the module mentions a couple of key therapies.
Yes, two stand out. Cognitive behavioral therapy, CBT, which we touched on, that directly helps people identify and change those unhelpful thought patterns, expectations, and behaviors related to substance use and develop healthier coping skills.
Okay, CBT. And the other one?
Motivational interviewing, or MI. This is a really interesting approach. It's very collaborative, client-centered. Instead of telling the person what to do, the therapist helps them explore their own reasons for wanting to change, strengthens their own motivation and commitment. It's about tapping into their internal drive for recovery.
That sounds powerful. Helping people find their own reasons.
It can be very effective, especially for people who might be ambivalent about change initially.
So listening to all this, the biology, the psychology, the social factors, the different treatment approaches, it really brings up an important point for you, the students listening. Considering all these complexities, where might you see your own future career fitting in?
Yeah, that's a great question to pose. Whether you're thinking about becoming a counselor or going into public health, policy making, social work, maybe even research looking into the brain mechanisms, having this deep, empathetic understanding of addiction is just invaluable. It touches so many fields.
Absolutely. Hopefully this deep dive gives you not just the clinical knowledge from the module, but also strengthens that sense of empathy for yourselves, for friends, family, for the wider community dealing with these issues.
That's the goal, to approach this difficult subject with both rigor and compassion.
We've covered a lot the four main drug classes: the brain science, the complex causes, the pathways to treatment. We really encourage you to take some time, reflect on these concepts, think about how they play out in your own lives, your relationships, and just observing the community here in Los Angeles.
And maybe one final thought to leave you with. We focused a lot on substances hijacking the brain's reward circuits, particularly dopamine.
Mm.
Think about how those same brain pathways, that same neurobiology of reward and reinforcement, might be involved in other compulsive behaviors. That the module also mentions things like gambling disorder or the more recently discussed gaming disorder.
Interesting. So the addiction process without the chemical substance.
Exactly. How might those patterns of craving, loss of control, and negative consequences manifest when the substance is actually an activity? That's something to mull over as you dig deeper into the module materials and the glossary terms, like the difference between, say, cannabis intoxication delirium and cannabis-induced anxiety disorder. Lots more to explore there.
That's a perfect place to wrap up. Definitely food for thought. Stay curious. LACC, keep digging into those module details, and we'll talk to you on the next deep dive.